Thank you. Good evening, everybody. It's a real pleasure to be here this evening, welcoming you all to the webinar today. I'd like to tell you all that we'd had such a successful ICA Con 2023 last weekend. This was the 4th International and the 14th National Conference, which was held at Narayan Vidyalaya, Bangalore. Our Dean, Dr. Kanchi, was the organizing chairperson, and they all, with his team, with his leadership, it was a very, very successful conference. We had more than 250 delegates who attended. Besides, we also had faculty, national and international. In the international, we had, of course, our international dean, Dr. Bilani, and along with him always, he gets many international faculty, and we had members from the ASA themselves, as well as from the SAMBA. So they were all, we had lectures from them, and they were very, very positive, and they were looking forward to a fruitful relationship and a continuation of some integration with our college. We had, the highlights were there, of course, which included 3 orations. Normally we have 2, but this time we had added 1 more, and this was for a very dear Dr. Kumra, who left us early this year. So this was the 3rd oration which was added in his name. And this first oration of Dr. Kumra was, we had requested his very, very favorite student, Dr. Vijay Vora, who's a stalwart in liver anesthesia fellowship, and he was the one who gave the first oration. The other orations were Dr. Manorma Mittal oration, which was spoken by Dr. Manjula Sarkar. She, as you know, is a very, very senior doctor, cardiac anesthetist in Mumbai. And late Dr. B.B. Shastri oration. Here the orator was Dr. Mukul Kapoor. He is our editor of the yearbook of anesthesia. So these were the highlights. And of course, the other highlight, as you saw in the background, was Professor, the CEO of the Narayan Vidyalaya, who was there, and he actually, Devi Shetty ji, he actually came and spent some time with us and gave us his few words of wisdom. So that was also another very exciting part of the conference. The other the points that took away, actually we can say that we were also keen to hear the mentorship program, which was started for the first time. And I must say it was a great success with Dr. Sanish as one of the panelists who was actually moderating the show. And we had a lot of participation. So coming back to today's program, this, of course, you can see the yearbook of Anesthesiology 13, which was released in this conference. It was, our yearbooks are really being appreciated by everybody here in India and abroad. And credit goes to Dr. Mukul, who is doing a very hard work for this. And this too should be read by all. Today is a very, very important program that we are having. This is on chronic pain, which is a difficult topic, difficult to manage. And the title of this webinar today is Managing Chronic Pain. Minimum an anesthesiologist should know, because we know that now we have pain specialists, and we are very, very lucky that moderating the webinar today is Dr. Nandita Mehta, and she is the head of the department in Jammu and Kashmir. In Jammu, she is the professor and head of the Department of Anesthesia and Critical Care and Pain Management in Jammu. She is affiliation with the ASCOMS and hospital in Jammu. She is a very, very senior lady, and although she looks, of course, very, very young, and she has many, many awards to her credit. And I know lately also she has got an award by the IMA for the creditable work that she has done, not only in COVID, but otherwise. Along with her, as the panelists are Dr. Babita Ghai and Dr. Vanita, I request Dr. Nandita to please introduce the panelists for this program. Thank you.
Thank you, ma'am. Thank you so much for your lovely words. So good evening, everyone. As we all know, that chronic pain and palliative care has been added to the curriculum of postgraduate curriculum by the NMC. And you all know that anesthesia people are very good at managing pain. But the thing is that they have to read a lot. And it's a entirely different part, and you have to dedicate few months to this specialty as well. So, it is important for us to know at least basic minimum what I mean. Chronic pain is now. It's about basic procedures and advanced procedures and so many holistic approaches there. But now everybody should know some basic minimum things. So, we are today talking about chronic pain and palliative care, because palliative care has become a very important part. And we have with us today Dr. Babita Ghai from PGI Chandigarh. She is the professor of anesthesia and consultant in charge pain clinic at PGI Chandigarh. And she has lots and lots of things to her credit. Her main areas of interest are pain management, education, and research. And she's holding a lot of international executive positions, like the co-chair of the Developing Country Working Group, IASP Presidential Task Force on Interdisciplinary Pain Treatment. Then she's a treasurer of pain education in the Special Interest Group of Indian International Association of Study of Pain. And she's the editor also in the Acute Pain Special Interest Group of IASP. She's a national board member of the discipline of pain medicine for DNB, FNB of National Board of Examination. And she's got many awards to her credit. And the last one is the ISA Presidential Award for Academic Excellence. She has a lot of publications in index journals and several national and international book chapters. So we over to Dr. Babita for today's session. She's going to talk about back pain, and which is a very common condition, and she'll enlighten you regarding that. But one request is, whoever has any questions or queries, please keep them putting in the chat box, and immediately after Dr. Babita's session, we'll take all your queries. Dr. Babita, over to you, please.
Thank you, Dr. Nandita, for your kind introduction. So I shall be talking about chronic low back pain, concerns and challenges. Before I start my talk, I just want to know, am I audible?
Yes, ma'am, you're perfectly audible.
Okay, thank you. So before I start my talk, I would like to say special acknowledgement to Dr. Nandita and ICA for inviting me and speaking about a very common and as well as very important topic as anesthesiologists we must know, that is chronic low back pain. Basically, why we say that it is important, now we know that NMC in the new curriculum has included chronic pain clinic posting of 3 months minimum for the MD anesthesiologist. So it has become a must in the curriculum of anesthesia, as well as maybe in the future we would also see lots of chronic pain cases being put on the examination purpose as well. I don't have any disclosures or conflicts of interest, barring one thing to disclose, that it is going to be a challenge to squeeze this broad topic in 20 minutes. So over the next 20 minutes, what shall I be discussing? About the definition, epidemiology, challenges in real pragmatic world, evaluation based on history, exam and investigations, management, and whenever possible, I shall substantiate my discussion with our research. What exactly is low back pain? Low back pain is a pain localized between 12th rib and inferior gluteal fold with or without leg pain. It is called acute when it is sudden onset and lasts less than 6 weeks, subacute when it lasts between 6 weeks to 3 months, and chronic if it is more than 3 months, or episodic in 6 months. So why we are discussing this topic today here in this forum? That's because all pain clinics worldwide cater to 80 to 85% of low back pain patients. And this is the entity which causes more disability worldwide than any other condition. It is also the most common musculoskeletal entity rated 4th in position in the top 10 list of diseases causing disability. It is continued to grow in years and projected to increase more so in lower middle income groups. We will be seeing probably an epidemic of low back pain, chronic low back pain in future. The prevalence is also quite high in Asian population. In coming to the Indian scenario, back and neck pain is ranked second leading cause of years lived with disability, second only after anemia, which is the most common entity. Various researchers have conducted the epidemiological study and found the incidence of 42 to 83% of low back pain in Indian population. However, the methodologies of these surveys were weaker. So we did our own first population-based prevalence finding study, which was an ICMR funding study to find the prevalence and impact of low back pain in northern India. We evaluated 1531 subjects in a very stratified, multi-level, systematic random sampling way, and we found that the lifetime prevalence was as high as 57%, 1 year prevalence of low back pain was 48%, and point prevalence was 32%. So this was the first stratified systematic population-based study, and we also reported a quarter of the patients did have impact on the sleep, mental health, and the social life. We followed the 872 patients who were having lifetime prevalence at 1 year, and we evaluated the psychosocial morbidity, and we found nearly 1/3 of them had severe disability, moderate depression, moderate anxiety, and their health-related quality of life was affected. So knowing this prevalence, we are discussing, because this is one entity which we will see in chronic pain clinic, definitely, ranging to, in our setup, we see approximately 80 to 85% of chronic low back pain patients. What are the professions at risk? Any profession which has a bad ergonomics or bad posture with prolonged sitting. So medical being the almost at the top of it, wherein anesthesiologists are the part of being at very high risk. Bad ergonomics, prolonged sitting, physical inactivity, smoking, obesity, and vitamin D deficiency are the risk factors. As I said, poor posture and sedentary lifestyle is the main cause of biochemical reasons of chronic low back pain. However, non-mechanical, mechanical, and psychological causes are also being seen. Like any other chronic disease, chronic low back pain affects all domains of life, be it quality of life, psychosocial aspect, the socioeconomic aspect, or the social consequences. Patients are depressed, patients are anxious, they have left with low resources because of the financial constraints. Now, coming to the chronic low back pain, what are the challenges in real pragmatic word? It is actually a very heterogeneous condition. Various pain generators are there, various pain categories are there, evaluation concerns are there, journal challenges are there, and management concerns are there. So how do we deal with them one by one? So contrary to the myth, the common myth of the public that chronic low back pain is mainly caused by only, PIVD. No, there are lots of various pain generators for the chronic low back pain, including muscles and ligament, bone, intervertebral disc. The PIVD is being only the one quarter of or one portion of this pain generator. Chemically or mechanically irritated DRG, dual or the dual sleeves, facet joints, sacroiliac joints, piriformis muscles, multifidus muscle, pars interarticularis defect leading to spondylolisthesis are one of the pain generators. But we have to remember that in real scenario, pragmatic word, usually a combination of pain generators are seen in clinical practice, and as pain physicians, we must identify all the pain generators and manage according to have the best outcome. There are various pain categories like nociceptive, neuropathic, and nociplastic, which is the definition of which is beyond the scope of this talk. However, we usually see the mixed type of chronic low back pain. With that background, let's come to the evaluation of chronic low back pain, which is history, exam, and lab test. And I want to emphasize that 90 to 95% of assessment of various pain generator is done based on the history. Hence, a very good clinical history is important. For assessment, chronic pain has to have multidimensional assessment, and it cannot be focused only on unidimensional assessment of focused only to pain. So when chronic pain is there, as I said, it affects all the aspects, all needs to be evaluated and managed. So the multidimensional assessment includes pain assessment, which I will just shortly talk about, functional assessment, psychological assessment, health-related quality of life, impact of chronic low back pain on all domains of life, red flag assessment, and yellow flag assessment. Coming to pain assessment, that is, I usually follow a mnemonics of LOPQRSTUV. And this is what I have printed it in my pain clinic file. And it is, so L is location, whereas the primary location is whether back or leg or both. Onset, when did it begin? How did it progress? How is it currently? Any provoking or relieving factor? And what is exactly the quality of the pain, which differentiate between neuropathic and nociceptive, or the mixed quality of the pain? Whether there is any region or the radiation involved, whether it is a referred, whether it has a dermatomal distribution, what exactly is the severity on a 0 to 10 scale or any other descriptive scale by which your patient can understand what is the past treatment, what is the impact of that past treatment, whether it has worked or not worked, any side effect of the past medication, what is patient understanding about the disease, what the patient has come to you with the expectation, whether the patient is expecting a zero pain with functional improvement, or whether the patient has realistic expectations. There are various types of back pain, as I said, which can be evaluated based on the history itself. If this is a myofascial pain, then it is characterized by multiple trigger points and myofascial tightening. Radicular pain is usually a sharp, piercing, burning, pins and needle pain distributed in the dermatomal distribution. It is classically increased by bending forward, sitting, coughing, or relieved by lying down. Discogenic pain is because of the internal disc disruption, which is low back, which is usually associated in the low back axial pain, groin or leg pain that worsens with the axial loading, or whether it is a spinal canal stenosis, which is usually notified as walking claudication, typically increases on walking and improves on immediate bending forward. Similarly, facet joint pain has a paraspinal or the pain or the paravertebral tenderness, which is low axial pain usually. Sacroiliac joint pain is usually tender at the sacroiliac point and with radiation to buttock, groin or lower extremity with the patchy radiation. Psychogenic back pain should also be ruled out. So that was only the pain assessment. We need to be doing the other multidimensional assessment in chronic low back pain. That is functional assessment, which is disability. What is the current status of the patient? And you can use whatever is being used as a questionnaire in your setup. We usually use modified ODQ, the Hindi version and the Punjabi version. Quebec low back pain, Ronald Maris scale can be used. We also must assess the psychological aspect using the screening tool. And if in the screening patient is found to be positive, then we must go for the structured assessment by the trained healthcare worker like psychiatrist. Health-related quality of life should also be assessed. Assessment concerns are there, which are as the topic also says, that we should be dealing with concerns and challenges. These concerns, these assessments, multidimensional assessment, which I just mentioned, are based on the questionnaires, which are usually self-administered. So they should be they should have linguistic adaptation and should be self-administered in the native language. Otherwise, physician may misinterpret the results or the essential construct of these scales. So what to overcome these concerns, we did do translation and cross-cultural adaptation of various neuropathic pain scales as well as the disability questionnaires. Like modified ODQ has been evaluated in our setup, Hindi version. Similarly, we have evaluated the 4 Hindi neuropathic pain Hindi versions. Similarly, we translated short DN4 and evaluated it in our setup. Similar is for the pain catastrophizing scale. The impact, having a multi-dimensional assessment of functional and psychological and quality of life, the impact of chronic low back pain on occupation of the patient, daily activity, social life, sleep, mental health, economical aspect, and spiritual health should be evaluated. The impact of it, like the patient has either had to leave the job or go into the part-time. Patient might be the sole bread earner of the family, and which would have the financial impact, and we need to be dealing with that. We should also evaluate the pre-existing psychological yellow flag signs, because that would prognosticate our outcome. Having evaluated all the aspects, we must move on to the examination. A physical exam observes the patient posture, spinal curvature, gait, which will tell you a lot of patient condition, whether patient is more comfortable standing or the sitting, whether patient has coccydynia, is not able to sit, patient has midline or paravertebral tenderness, what are the range of motion. We must also do the dermatomal sensory examination to rule out any sensory neuropathy. Similar for the motor neuropathy, we must examine the reflexes. We also need to go for some of the provocative maneuvers which can tell us the various pain generators. The seating straight leg raise test, or the seated straight leg raise test, or SIG evaluation like Feber, or the distraction test. Investigations should be individual need-based investigation. The American College of Physicians and American Pain Society recommends that clinicians should not routinely obtain imaging or other diagnostic tests in patients with non-specific low back pain, and it's usually natural course of the diseases to improve. However, AP and lateral lumbar spine X-ray should be done if no clinical improvement is seen after management for 4 to 6 weeks. And the performance of the X-ray is indicated in less than 4 weeks if there are other signs like fever, unexplained weight loss, hence history of cancer or neurological deficit. MRI is recommended after the patient is not improved for 4 to 6 weeks of management. It is more sensitive for detection of the infection and cancer than plain films. Also able to image herniated disc and spinal stenosis, but we all must be very clear that herniated or the disc, bulge disc are often seen in asymptomatic volunteers, and that should not lead to overdiagnosis. We must corroborate the clinical findings with the MRI findings. Moving on to the management. What are the goals of management? Most important goal of management is not just the pain reduction, but the functional improvement, that the patient is able to return to the work, should have participation in recreational activity, should have reduction in narcotic use if they are, and reduction in healthcare consumption, and not just the pain reduction. So what are the management for chronic low back pain? There are first line high value management, which should be really focused on, which is usually forgotten. That is the non-pharmacological management. Along with that, as an adjunct, we can use second line management if first line management is not working, with pharmacological or minimally invasive spine and pain intervention, which we usually mnemonic as MIPSI. Surgical intervention is only limited to the only select of patients. So what exactly is high value first line management? Self-management of the patient, advice to stay active. In self-management, I shall be discussing what the patient should be taught about, exercises, and psychological support. So the patient education is extremely important. Why are we saying that we call these first-line management as the high-value management? During the past 3 decades, the changes have been made in the key recommendation in the clinical practice guideline, and greater emphasis is made on self-management, physical therapy, psychological therapy, and less emphasis on the pharmacological and MIPSI or surgical treatment. There is a Lancet working group for low back pain who had evaluated, and guideline messages to move from biomedical and surgical aspect to biopsychosocial framework of chronic low back pain management. Despite all guidelines mentioning their emphasis on high value first line non-pharmacological management, these are highly underused both in high income as well as low income group. Disparity between the 10 guidelines recommendation and reality of this is because there has been a limited use of first line management, which was provided in less than half of the patient, which is provided to less than half of the patient. What are the reasons despite available evidence? What are the reasons of these underused first line management? That is probably because of the short consultation time, especially more so in lower middle income group, where they have a busy pain clinic, clinical poor knowledge or the misconception about the clinical guideline, fear of litigation in the event of missed rare or serious pathology, a desire to maintain harmonious relationship with the patient. So what are these are very highly recommended self-management or the first line management. In the self-management, patient should be advised and educated about the nature of the disease, about the reassurance that there is nothing serious going on, no cancer is being there or carcinoma incidence is not there, encouraged to avoid bed rest, stay active, and continue with the usual activity. Psychological support is also should be given to the yellow flag sign and consideration of the psychological therapy, which is emphasized. These are the screenshot emphasizing NICE guideline recommendation. Moving on to the pharmacological management, which is a second line management. Patient not responding to first line management should be moved on to the second line management along with the first line management. Role of acetaminophen is questioned in the recent guidelines. However, NSAID and cyclooxygenase 2 selective NSAID should be used only for short term. Skeletal muscle relaxant have only low evidence. In patients with neuropathic radicular pain, role of antidepressant and the gabapentinoids, anti-epileptic like gabapentinoids has been seen as a A1 evidence. I usually use amitriptyline, but amitriptyline, nortriptyline are the TCS being used. For the anti-epileptics, we use gabapentinoids as a first line. However, the new evidence is insufficient regarding these A1 evidence which was seen in the past. Opioids only have a A2 or the C evidence. This is also from the Lancet Low Back Pain Series working group, which also re-emphasize what I just mentioned. A striking observation I want to share is that very lower doses are required for our population for the neuropathic radicular pain, we have seen patients going dozed off or going to the sedation and having dry mouth in as high as 40%, with amitriptyline as low as 5 milligram, or pregabalin as low as 50 milligram, or gabapentin as low as 100 milligram. This is not just our observation. This has also been proven by the publication with the survey of 281 doctors across India, wherein they have also reported that very low doses are required. Why do we as an Indian population require low doses? Probably because we have a smaller body size. Indian patients may perceive pain differently because they may respond to treatment in a different way, or they might have been different genotypic or genotype or the phenotype differences across the compared to the Western population. Moving on to the second, another line of management as an adjunct therapy to first line is minimally invasive interventions. These are epidural injection, including either of steroids or local anesthetics. We usually use steroid along with local anesthetic through the various routes, which is transforaminal, interlaminar, or caudal. These are used for the refractory radicular pain. RF innervation are included in the UK guidelines. The other minimally invasive MIPSI is sacroiliac joint injection or piriformis or caudal route, which is a part of epidural injection. Epidural steroid injection have a logic in treatment of radicular pain because they deliver anti-inflammatory through near to the annulus, and the presence of inflammatory markers as high as 40 times the phospholipase A2 or tumor necrotic factor has been reported in the disrupted disc. Studies have shown that caudal, interlaminar, or transforaminal route have provided short-term or the intermediate term effect. Moving on to the other MIPSI, that is facet joint injection, has a limited level 3 evidence. However, median branch block denervation has a level 2 evidence. Having said or briefly concising what I have, covering up all the aspect of low back pain, how do we manage and what are the SOPs at PGIMER? So what we do that we take after taking a thorough multidisciplinary management assessment, we educate the patient about patient's disease using this back care booklet, which is available in Hindi and Punjabi as well as in the English. We counsel the patient. Our trained nursing officer or a research officer spend good 15 to 20 minutes or maybe half an hour to new patient. So this busy clinic can be looked after by the trained workers. In our setup, we have made them trained. So we give them good posture advice. We give them good ergonomics at workplace, home, or the lifestyle modification, weight reduction if required. So we give them this booklet of and which has a pictorial representation of how to sit, how to do the basic exercises. Once this is done, we prescribe them hot fermentation in lateral or the sitting position for 20 minutes to increase the vasculature of the muscle, but not in supine as it increases the lordosis. Local gel application, exercises BD. I tell them that to live, they need to eat 3 times. So to keep their spine alive, they need to do at least 2 times the exercises. If not 2 times, they should do at least 40 minutes a day, and they should break up. If that is also not possible, they should break up for the 10 minutes of 3 times. Vitamin D replacement, and I actually prescribe this on the OPD card. It is actually handwritten to give them the high value first line importance. So what is our research? I will just go through that. This is back care booklet is created by the group of experts. It has also been validated in 132 patients. So it is not just non-validated a booklet which has been given, and it has been published. Similarly, what do we do further if the patients are non-responded to the first line management? By the time they reach to the pain clinic, which they are usually with radicular component, then we prescribe them amitriptyline 5 milligram at bedtime. Mind it, in India, we do not get less than 10 milligram or all over the world. So we tell them to start with half the tablet and then increase after 1 week. Gabapentinoid 50 to 75 milligram pregabalin or gabapentin, tramadol or tapentadol or if required, PCM or NSAID on the SOS basis. We follow them after 4 to 6 weeks if the pain relief and the functional improvement is more than 50%. We continue the same treatment if 30 to 50% dose titration or escalation is done. If it is less than 30%, MIPSI is done. So what is our research work on the biopsychosocial framework? I'll just quickly do that in 1 or 2 minutes. That we have developed an integrated approach of yoga therapy with SVASA, Bangalore, and we have created a module and we evaluated, we just not created it, we evaluated this on the as a pilot study in chronic low back pain patients, and we just recently published this. A big step forward is that we have got a DST Satyam project sanctioned to us, with myself as a principal evaluator to evaluate the long-term effect of integrated approach of yoga therapy on physical and mental health of the chronic low back pain patient. We have also done bedside pharmacological managed research wherein we showed that lesser doses are required. Our experience on MIPSI is that we have 4 RCTs comparing PIL with MIL, PIL with transforaminal, PIL with local anesthetic or with or without, Cambinet triangle approach. And we have reported that PIL has shown a better effect than MIL. PIL is equivalent to transforaminal. PIL LA plus steroid may provide superior effectiveness in terms of extended duration. We have also evaluated the effectiveness, a safety profile of MIPSI, wherein we evaluated the HPA axis. This is the only and the only RCT available of evaluating HPA axis in epidural steroid patient. We have also evaluated the role of vitamin D. We have evaluated the high prevalence of vitaminosis in Indian population with chronic low back pain, which was DST sponsored study. We have also evaluated the role of vitamin D supplementation to these chronic low back pain. So what exactly is the take home message? Low back pain is a major global health issue. It has the major goal of management should be functional improvement and return to work, and not just the pain improvement. Emphasis is required onto the implementation of evidence-based first-line non-pharmacological management and moving from biomedical to biopsychosocial framework. And more evidence is required from lower middle income group. And without collaborative effect, this expenditure is very impossible to decrease. So it is a teamwork, and low back pain is not difficult to manage. Thank you very much.
Thank you, Dr. Babita. It was a very nice talk, and in such a short time, you have covered so much, and you have covered every aspect of back pain. And I'm sure
Thank you very much.
The audience would be very happy to see how you are managing back pain. And I'm also very happy that in my alma mater, so much of work is going on back pain. Congratulations. So if somebody has any questions to ask, you can ask right now, because Dr. Babita has to leave the meeting right now. So if any questions, please, we can take the questions.
Ma'am, I have sent one question in the chat box.
What is the role of TENS, ma'am? So somebody wants to, Dr. Divya Sai wants to know the role of TENS in back pain.
Okay, Dr. Divya, yes, the role of non-pharmacological modalities, including the physical therapies, the TENS, is there in select of patients. However, when we go to the evidence finding, most of the evidence for for the physical therapy is not beyond level 2. So it is level 2B, which has shown. However, we usually see most of the evidence as level 3. So you have to really decide your patients, select the patients who have a low axial pain, who has more of a myofascial component. They might be a better responder to the TENS therapy. But whenever you're using physical therapies like TENS or a laser or a electrical shockwave therapy, you have to choose your patients. Most of what I have seen, that most of our patients who have shown a good response to the hot fermentation usually are responsive to these physical therapy. So TENS do carry a role, but it is basically what I want to tell you, that multimodal management, the spice of multiple things together would make a curry very tasty. So this is where we need to explain it to the patient that multimodal management would be required.
So, okay, Dr. Babita, I would like to ask from my side is just one query for the audience. Like, how do you decide about the investigation part? Like, how do you go about investigating a patient? A patient comes to you with backache in your OPD. How do you decide the management investigation?
Okay, so let's talk about a real pragmatic scenario here. So there are 2 types of pain clinic. One pain clinic is where the patient is the primary pain clinic, wherein the patient can walk in. You can see any chronic pain patient as a first new patient. Over there, you need to be investigating the patient based on the individual need. So what we are doing currently in our setup, and most of the worldwide, the pain clinic are the referral clinics. Okay, so the patient is probably being referred either from main chunk of the patient comes from orthopedics, neurology, neurosurgery, with chronic low back pain be the most common. So by the time they reach to us, they are on an average, what we did studied in 500 patients, their duration of chronic low back pain is ranging from 1 year to 14 years. Okay, so by the time they are coming to you, they have already been investigated for the imaging. In fact, they have been over-investigated for the imaging. Even they have also been investigated within the first 4 weeks of the illness without giving them the natural course of the disease to settle down. So most of our patients are already having MRI or the blood investigations, like they might have been evaluated for, if they have a unilateral sacroiliac joint, have been already evaluated for rheumatoid arthritis, young patients. What they do not have is usually a baseline blood investigations. Sometimes they might not have been evaluated for the diabetes. They may not be. So I do generally the screening test and I get them the vitamin D3 level done. This is what we learned from our RCT, and more 90%, 83 to 90% of them have a low vitamin D, which may not be the cause, which may not be the etiology, but which is associated with the chronic low back pain. So we treat holistically the same thing. And very rarely we need to get the imaging done. Only in 2% who did not have the imaging, we need to get it done.
That's right. Basically, lots and lots of patients with backache are actually patients of spondyloarthropathies. And a good, like rightly said, pointed out that a good hematological investigation is required. The blood ESR and CRP and other inflammatory markers need to be seen before you jump on to MIPSIs. Because we have our young budding physicians, they have a tendency to go in for in all these invasive treatments. But first of all, we have to manage the patient holistically. So first, don't just treat the MRI, don't just treat the X-ray, treat the patient. Whatever the patient is having, treat that. Thank you so much, Dr. Babita. It was a lovely.
Thank you. I would just like to add one thing is that sometimes we see a disc prolapse para-axial, a transforaminal on left side. However, the patient have a right side dermatomal distribution. So we must treat the patient. Second thing is, whole of the topic was based on focus on, if I have passed the message that first line high value management is extremely important, then my job is really done. Thank you.
Thank you, Dr. Babita. Thanks a lot. So we move on to our next speaker, Dr. Vanita. Dr. Vanita, you can share your screen now. Yeah, Dr. Vanita Ahuja, she's a professor at Government Medical College and Hospital, Chandigarh. And her main areas of interest are regional anesthesia and chronic pain and research methodology. Can you please share your screen, Dr. Vanita?
Vanita, you were already sharing the screen.
But something happened.
Yeah. You need to unmute also, please.
Vanita ma'am, you need to share the screen once again. It has stopped.
Yes. I'm just sharing it. Please just give me a minute.
Okay, ma'am. No issue.
I had opened the PPT, but it's not showing right now. I'll just do it again. Probably just give me a minute.
And I just want to say that I might be staying for 15-20 minutes more. So if still more questions, I can reply in chat box.
Thank you, Babita. Thanks for that. Dr. Vanita is going to speak on a very interesting topic, which is also very important in pain clinics, you will see, and that is about the facial pain. So before we go on to the topic, I would like to introduce Dr. Vanita, who's a senior person in pain management, and her special achievements are the ICA Best Reviewer Award in 2016. She's an associate editor, Indian Journal of Anesthesia since 2019. She's a co-convener research committee at the Medical College, Chandigarh, and she's an author and co-author in several best papers. And she has more than 100 publications in international and national reputed journals. Over to you, Dr. Vanita. Dr. Vanita is going to talk about atypical facial pain. So let's see what she has to say. It is a very important topic.
Right. So am I audible, ma'am?
Yeah. Yes, Vanita, you are.
So a very good evening to all my senior faculty members and participants. As we can see in this figure, the pain, pain is this, and what we see sometimes is this, and maybe sometimes this, but the patient is this. So I'll just start with my talk. Before the patient presents to us in the pain clinic, he has been seen by several people, as we can see from the list, So when the patient arrives at our clinic, he or she has probably, gone through so many physicians that they feel that whether they're having a pain also or not, on the face. So as we can see, the trigeminal neuralgia has a 0.3%, of lifetime prevalence, which is very commonly seen, 0.3% prevalence. And what we see as atypical facial pain is a very small percentage of that. But facial pain is not only trigeminal neuralgia or atypical facial pain. There are so many pains which can occur on the face. So we need to take all these points of history, which were very beautifully elaborated by Dr. Babita, that when did the pain start, whether the pain is unilateral, are there any autonomic symptoms, what is the pattern of the pain, what is the quality, how severe it is it interfering with your sleep, what are the other, associated events, is the patient getting more depressed with these symptoms or getting more anxious, what are the treatment they have received and how they have, felt with those treatments, and are there any associated other chronic problem ailments. So when we come across face pain, we can, primarily categorize them either, having a unilateral or continuous type of pain, or a unilateral and episodic type of pain. So the most commonly seen unilateral continuous type of pain, the blue boxes are the pain of neuropathic pain, having a primarily a neuropathic pain. So like after post-herpetic neuralgia or, traumatic trigeminal pain or, anesthesia dolorosa. Now, these are the vascular pathology, unilateral type of pain and migraine, and of course, cancer pain, Dr. Nandita would be talking to in the next talk. If you have a unilateral, an episodic shock type pain, so the most classical is the trigeminal neuralgia. Then we have the glossopharyngeal neuralgia. And then there are other variants of trigeminal autonomic cephalgias, which I'll be talking in the subsequent slides. So what is the classification of trigeminal neuralgia? What we talk about the classical, how do we know whether it's classical or not? On a demonstration on an MRI, there'll be a neurovascular compression, which is not just going to be a simple contact, but neurologically, it has to have a compressive effect on that. So that comes under the classical. Idiopathic is when you're not able to find a cause. The diagnostic tests have excluded a lesion or a disease, but the patient still complains of episodic pain. And secondary trigeminal neuralgia is due to an underlying disease, whether patient's having a multiple sclerosis or any other secondary cause, which can be, traumatic, but it cannot be a neurovascular compression, because in that it comes into the classical. So what is the ICHD criteria for diagnostic trigeminal neuralgia? It is a recurrent paroxysmal of unilateral facial pains in the distribution of one or more divisions of the trigeminal. You can see the ophthalmic division, the maxillary division, and the mandibular division. What is the character of pain? It will be lasting from a fraction of a second to 2 seconds. Patient will say, oh, it just came and it just went away. It will be very severe. It will be shooting like of pain. It will be precipitate, like, patient is just having, maybe drinking water, maybe just, stroking a hand on the face. So anything can cause it. Very, very innocuous stimulus, which will normally not cause any pain. And it is not better counted by any other cause. So you can see these are the causes of the chronic peripheral neuropathic pains. So trigeminal neuralgia falls into it. And these are the chronic central, which Dr. Babita just talked about, and the spinal cords. So we just talked about the etiopathogenesis of trigeminal neuralgia, and this is the pathogenesis. So what is the hallmark? You see these dots on the face. So the patient will be, pointing out on these trigger points. They'll say, pain is on this area. Pain is on this area. They'll be, marking those areas, as a trigger points. And they'll be as a result of these light tactile stimulation, like, I just talked about, like talking, chewing, brushing, all this will, trigger the pain in these patients. And there will be, one more important thing would be the refractory period. Between the two attacks, patient will be pain-free. Then there are other variants are trigeminal autonomic cephalgias, in which there'll be autonomic symptoms, which will be lacrimation, rhinorrhea, hypersensitivity. So they come under the trigeminal autonomic cephalgias. So what we talk is for the classical, in which we were, when I spoke about the vascular compressions. So we need to get them evaluated. Just to make a difference between the trigeminal neuralgia and the SUNCT. SUNCT is the or the SUNA, which is the short-lasting unilateral neuralgiform headaches, and they have autonomic symptoms. So you can see that the most common variant of trigeminal is the V2, which is the maxillary. And of course, there'll be involvement of the branches of the trigeminal nerve. The pain would be very severe, but you can see there is a difference in the duration, which would be more in the SUNCT, which are the autonomic ephalgias, which have the prominent autonomic features like conjunctival injection. They'll have a redness of conjunctiva. There'll be headaches, will be neuralgiforms. There'll be eye tearings. All that will be present. And then they will be having, refractory period would be absent in SUNCT, whereas it will be present in the trigeminal neuralgia. It's more chronic and it's going to be more episodic, and the treatment is different. In trigeminal neuralgia, the drug of choice is carbamazepine or oxcarbazepine, whereas in this, it is lamotrigine. So what are the treatment? I just told you the drug of choice is carbamazepine, oxcarbazepine, and the other drugs can be added on. The surgeries which have been offered are, some are invasive, some are non-invasive. And as pain physicians, we give, the radiofrequency, pulse radiofrequency and radiofrequency ablations, plus the peripheral blocks that can be used as a diagnostic part. And then there are other additive pharmacological agents which can be used. What is important to understand is that in this complete list, we are only seeing drugs which are acting on the neuropathic pain. So they're having a component of neuropathic pain. And it is not that immediately they take the medication and the pain relief would be there. It takes time. It takes time to build on pain relief. Of course, they will get the side effects like, drowsiness or dizziness or, these type of side effects would come, immediately. But the pain relief of neuropathic pain would take some time. Rather, it takes almost, up to 72 hours to 1 week to have a good, pain relief. And of course, we need to increase and titrate the drugs. And before this, we need to have a baseline, HB, TLC, DLC, LFTs, RFTs, a baseline medication investigations in these patients. So this is the list of drugs. This is what I talked about, the pulse radiofrequency, which is a type of a neuromodulation, and radiofrequency ablation is type of a, ablating, denaturating the proteins. So this is the, you can see the foramina veil where we have a needle placed. And here is the lateral view. So this is the invasiveness, and this is a pulse radiofrequency. So besides trigeminal neuralgia, we as, anesthesiologists should be aware of the other causes as well. I told you about the neuropathic components, like the type of pains that we get. These are the trigeminal autonomic cephalgias. Then what are the others? Others are the dental pain, the maxillary sinusitis, the salivary, the TM joint. So these are very important type of other pains. But then there is one more component, which is atypical or the chronic persistent facial pains, which doesn't fit into any of these categories. In this, the pain is, a daily it stays for more than 2 hours, and that's for being experienced by the patient from a duration of up to more than 3 months. The patient says they have a poorly localized type of pain on the face, which is dull, aching or nagging quality. And all the neurological examination is normal. And a dental cause has also been excluded by the appropriate investigation. Now, these patients are the ones where, they say, okay, you don't have a cause, it means you are just, making up the pain. No, it is not. We have 3 components, the nociceptive, neuropathic, and the nociplastic. So nociceptive is basically from unidentified nociceptors. The classic example is like what we see in the degenerative osteoarthritis. Neuropathic is when you have a lesion, whether the peripheral nerve, even up to the somatosensory, up to the brain. So you're having a lesion somewhere which is present. And nociplastic is that neither there is nociception nor there is damage, but the patient is still having pain. The classic example for this is fibromyalgia. So now coming back to the persistent, facial pain, which can have neuropathic component, it can have a central cause, and it can have, some amount of even as a part of even a peripheral myofascial pain component also. So what you can see is that we talk about the upper trapezius pain having a, potential etiology for persistent idiopathic facial pain. The pain would persist like this. So it's neither a nerve, it's neither any dermatome, but, it will present like this. So these are the various presentations, where the patient will say, oh, I'm having a pain here and I'm having a pain here. So how do you explain? So these myofascial component of the persistent idiopathic facial pain will have a somatic component as well. So how do we go about it? First of all, the history which the patient has given to us. Then we rule out the other causes. Whether there's a dental cause, okay, then it doesn't fall in that category. Whether there is any other, infection, we have to treat that infection. If there's a TM joint pathology, we need to make sure that the patient is referred to the, and other causes. If you're not able to find any cause, then you have to find out whether it's a somatic cause, neuropathic cause, and whether it's a combination of both of them. So you need to do investigations as highlighted earlier. But the challenges with persistent idiopathic facial pain is that you're not going to get any clear cut, but the patient will have symptoms, but there'll be no clear cut, as a cause. But yes, you may get some positive sensory or negative sensory, problems. And but then it is actually a diagnosis of exclusion. So what is the current evidence for use of persistent idiopathic facial pain or the atypical pain, which it was previously called? So the drugs that can have been used with some evidence which is available, although there is not much evidence, but what some evidence is present is the use of tricyclic antidepressants, serotonin norepinephrine reuptake inhibitors. In anti-epileptics, it is lamotrigine. Then some cannabinoids have been used, low-level laser, which is by a part of the physiotherapy, cognitive behavior therapy, and sphenopalatine block. So we know that tricyclic antidepressants are sodium channel blockers. They have serotonin and norepinephrine reuptake inhibitors, and there are multiple other, modalities by which these amitriptyline act. Start with low dose. You need to take your main precautions. What are the other major adverse effects? They can have cardiac effects. Need to be cautioned in patients having seizures or, having a cardiac problem, having glaucoma. So these are the precautions that we need to follow with these patients. Then serotonin, norepinephrine reuptake inhibitors, the duloxetine and venlafaxine can be done. And I just want to mention that the number needed to treat with the tricyclic antidepressants is very good. So they are a kind of a drug of choice. Duloxetine has a need to be taken with caution in patients of mania and seizures. And lamotrigine, I talked about, it is a voltage-sensitive sodium channel blocker. And you start with low dose, start with 25 mg, then you build on the dose. And if you have to discontinue lamotrigine, then you do it in a stepwise over a period of 2 weeks. So the low-level energy diode can be used by physiotherapists. The other modalities which are more invasive, you can use the peripheral nerve field stimulators, which is the first order neurons. You can use spinal cord, which are the second order. And for the third order, we have the other we have the non-invasive also. And sometimes we can use other invasive part of the modalities also. The non-invasive is your transcranial magnetic stimulations. It is non-invasive. The patient comes to the clinic, gets a session of few hours, and then goes back. So this is non-invasive. So to come back now, the facial pain actually requires a very detailed evaluation. I just talked about from very, severe pain like trigeminal neuralgia to a pain which, doesn't have any positive findings like the persistent idiopathic facial pain. So what is more important is a history. Listen to your patient, believe your patient, and pain can be anywhere, right from the fascias, muscles, bones, nerves. So we need to evaluate them completely, whether it's a truly facial pain or a neck pain from the back coming onto the face. So we need to, first of all, take a history in the detail, evaluate, and then, go for investigations. And prevention, education of the patient, medical management, and evidence of the interventional pain is required. So we have a patient coming up with like a stone type of face. I hope we are able to give them a smiling face. Thank you.
Thank you. Thank you, Dr. Vanita. That was a lovely talk. Basically, orofacial pain, whenever the patient comes to our clinic, we always think of trigeminal neuralgia, rightly said. But then gradually, once you start taking the history, and then you realize it's not neuralgia, it is a neuropathy. And then sometimes you have patients, there's a very overlapping picture of glossopharyngeal and trigeminal as well. And then even for these cluster headaches and SUNCT and all, they all are overlapping. You're right. And for the myofascial pain, what is your take on this botulinum toxin or dry needling? Have you ever tried these in your patients?
Ma'am, definitely Botox has an evidence in facial pains. Yes, it does have a evidence. And first of all, of course, I'll be doing my diagnostic blocks. If I'm satisfied them, it can be offered to patients. Definitely, yes, it is.
Because I've seen in many workshops of chronic pain, I've seen many people doing dry needling.
Dry needling, yes. Dry needling has a very good role, ma'am.
For the trigger points and myofascial pain.
Yes, ma'am. It has a very good role.
So we have one question in the, should we take the questions right now?
Yes, ma'am.
There is one question by Dr. Divya Sai again, and she wants to know, how do you give carbamazepine, number one. I mean, how do you build up carbamazepine? And secondly, she wants to know whether there is any specific, why there is specific response to trigeminal neuralgia with carbamazepine, why people are responsive to carbamazepine only and more than steroids.
Okay. So first of all, when a patient comes to the clinic and has been diagnosed with trigeminal neuralgia, we start with carbamazepine depending upon, the body habitus of the patient and asking them whether they have ever tried this medication or not. There are patients who must have taken these medications and then they have stopped in between. Normally in my Indian scenario, where if it's a woman, I start with very low doses. I start with like something like 100 mg. Maybe I'll try it, give it a BD. Then I'll tell her to, titrate her sleep with the pain relief and maybe then go for TID. And then once she has tried this therapy for maybe 10 days or 15 days, and then maybe, increase the dose to maybe 200 in the morning, 100 in the afternoon, and maybe 200 in the evening. So that is how I titrate and build on the carbamazepine. Because, patient, if you give a very, if you give 200 mg TID, the patient would sleep after 2 or 3 doses, and then they are scared, they don't want to take it because they are not able to do their household work. They feel so dizzy, they feel syncopal. They say, no, I will not take this medication because I don't have a control on myself. So that is one thing. So first the patient should have confidence into what is being given to that patient, and then we can increase. I tell them, like, initially you might get symptoms more than the pain relief. And once I built on the dose, you'll start getting the pain relief. Of course, the number of episodes also reduce. That's how they, come up with it. They say pain is coming, but the number of episodes is reducing. This is the first thing they come and tell me. And then we build on the dose, then they say, oh, even the pain is coming down.
And yes, definitely, even baclofen has a good role in these patients. If they have a persistent pain, which is not responding to the heaviest doses of carbamazepine, or they are getting side effects with carbamazepine, you can shift over, you can add baclofen, but that too, again, with a caution, very small doses, because patients are very, very apprehensive about taking baclofen. They get a lot of dizziness with that.
And the second part of the question was that why carbamazepine acts. Carbamazepine has, the sodium channel blockers, and the channels, they're different. They are all action evoked potentials. So basically, the trigeminal nerve, that there's a myelin, sheath is, eroded on that, or there is something to do with the myelin sheath of the nerve, So the pathogenesis itself has an evoked potential. We all know that it's stimulated by the sodium. So when it blocks the channels, it has been seen that it works better. It's not that gabapentin, if you add with the, carbamazepine, it's not going to work. It works. But, the drug of choice, because of its carbamazepine, its unique action on the sodium channels and the other associated, it stops the, activation of your, your excitatory amino acids like glutamate, and, so that is how it controls a pain in a better way as compared to other drugs of neuropathic pain.
Yeah, that's right. Thank you, Dr. Vanita. Any more questions from the audience? Because I can't see anything in the chat box. Dr. Babita has given a comment about the carbamazepine. Yes, this is a very long-acting drug, and it has been newly introduced. And people are using oxcarbamazepine as well. People, if they get side effects with carbamazepine, they shift over to oxcarbamazepine. These are the various drugs, but they are from the same group, actually. Yes. So if we have no more questions, thank you, Dr. Vanita. Then I go on to my own topic. That is about palliative care. I'll just share my screen. And Dr. Vanita, you can stop sharing your screen. I can. Yes.
Let me take the privilege of introducing you, Dr. Nandita.
Yeah, please.
Yeah. So Dr. Nandita Mehta, she's a dear friend. She is head of department of anesthesia and critical care and pain management at ESCOMS and Hospital Jammu. She has a special interest in chronic pain and acute pain management and regenerative medicine. I've heard, delivering wonderful talks about the regenerative medicine talks. She is a certified she has a certificate course in palliative care from April 2022, a fellowship of Indian Association of Pain Management in 2021. She is also a fellow of Dardia Pain Hospital for 1 year. She is also a fellow of pain management at Atypical Academy. She is also a fellow of Indian College of Anaesthesiologists, which is actually a big award, a fellow of International Medical Science Academy. She was a clinical observer at Dudley Group of Hospitals, NHS Group at UK for chronic pain management. And she does have several publications to her credit. She has been the past president of ISA North Zone from 2014 to 2015. And she is also the past president of Jammu Society of Anesthesiologists. Over to you, Dr. Nandita.
Thank you so much, Dr. Babita. Thanks for doing the honors. Now I'll go on to my topic, which is like managing pain in palliative care. So pain is pain management is the critical component of palliative care. And, inadequately treated pain in palliative care is a big problem, because these patients, they are suffering so much that they don't like to share their experiences. They are inadequately reporting their pain. And even the physicians are very much scared of treating these patients. Since the pain is underreported, so it is undertreated, both by the doctors and the healthcare professionals. So basically, the reason for undertreatment is the attitude towards pain, misconceptions about painkillers, and underprescription, which act as a barrier to pain relief. And there are unnecessary sufferings of these millions of patients. So now, what is palliative care? Palliative care has been there for a long time. Basically, it's not, first of all, I would like to say that my objectives for today would be to define pain, to evaluate a patient with pain, complaints of pain, and describe different types of pain in palliative care, and explain the basic principles that I'm going to just touch them shortly, and address common misconceptions and barriers concerning the pain management in palliative care. So I'm not going to touch upon chronic pain management, details of interventional procedures, palliative sedation, or therapy for opioids and addiction. So what is palliative care? Palliative care has been there for a long, long time. Especially in our country, we are in the habit, we have been given that as a values in our families to look after our elderly, to look after the sick people. But now palliative care has become very important, and it has become very popular, because the concept, although is not new. Palliative care is an approach which improves the quality of life in patients who are suffering from either life-threatening diseases or even incurable diseases. So these patients, it's not only about the patients, it's improving the quality of life of the family as well. So we as caregivers or healthcare professionals are responsible. From this chart, you can see from this that what we can see is that palliative care comes towards the end. Initially, you start when the patient is diagnosed. After the diagnosis, the curative and life-prolonging care starts. But as the disease progresses, the curative part goes on decreasing and the palliative part keeps on increasing. So that is the role of palliative care. I can't go into the details of what palliative care is, but this is briefly what palliative care is about. So how do you define pain? So this webinar or any seminar on pain management would be incomplete without the international definition of pain, that is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Now, this definition has been given new dimensions, and new dimensions have been added in the year 2019. So now pain is not so simple. From this definition only, you can see that pain is not so simple. Pain is, it's not only about physical pain, it's complex. It's like about emotional part also. So a simple definition of pain by Robert Twicross said, pain is what hurts. So no definition of pain can bring about this part. So it is a multidimensional aspect of pain you have to see. So the word is total pain. Now, this total pain concept was given by a nurse, Dame Cicely Saunders, long time back. She's a person who has done lots and lots of work on palliative care. And she was the one who gave the concept of dying with dignity. So according to her, total pain, it's not about physical pain only. It's total pain the patient is suffering. In simple terms, pain is not simply like about the patient is having some injury or some wound or some nociceptive type of pain. It consists of many dimensions like psychological, spiritual, social. These interact with each other and in fact fuel one another. And it teaches us why sometimes despite taking painkillers, patient does not get relief because there are no receptors for spiritual or financial concerns in the brain. So that is why it is very difficult to treat these patients. So you have to have a holistic approach to these patients. You can't just treat one part of pain. But today, mainly, I'm going to talk about the physical part of pain because it is very difficult to cover whole of palliative care in just 20 minutes. So the prevalence of pain in palliative care is very high, as you can see. It is almost 70 to 90%, which goes on increasing as the patient approaches the end of life. But you just see, it's not about palliative care is not only about cancer. It is about chronic obstructive airway disease. It's about renal failure, congestive heart failure, stroke, and all these conditions have a high prevalence of pain. So, and the median is very high. It's not like even the congestive heart failure patients and even obstructive airway disease patients have a lot of pain, which the physicians are not actually tackling. So what are the barriers to pain management? The barriers include inadequate education, both of the family, patient, and even of the healthcare provider. Then there are a lot of fears and myths about using drugs. And also they're not prioritizing pain as a entity. And it is very difficult to say that there is failure to manage adverse effects. There is inadequate follow-up process, limited accessibility to resources, and fears about opioid addiction. And of course, the culture and religion, because people think that you are having a disease, you have to suffer. And definitely our Indian populations, they're not in the habit of complaining about pain and they don't report pain. So for any pain, any kind of pain, like already discussed by Dr. Babita and even by Dr. Vanita, you have to have a good history. So when you're taking the specific history for pain, you in palliative care, you have to see the PQRST. First is onset, when did it start? What are the aggravating factors? What are the alleviating factors? And what is the quality of pain? When we say quality, whether it is nociceptive or whether it is neuropathic. When we say nociceptive, that means that whether the patient is having pain like a pain of a wound, or whether it is a burning pain or a lancinating pain or a pain which is causing, it is neuropathic kind of pain. And then radiation. When I say radiation, it means where it is going to. And then severity. That also, everything, even the relation of pain to timing, whether it is at night, whether it is all through the day, whether there are certain associated features with pain, all these things to be ruled out in the pain history. And it is very important to see what kind of pain it is and what is the it is also important to have there is no thermometer to measure pain. So what happens is, like, whenever we are seeing a patient of pain, we have to believe the patient. Whatever the patient is saying, we have to believe. We cannot say that this patient is lying. So, but there has to be some tool to say that this is the amount of pain patient is having, because if you have some tool which can measure pain, then at least you can see the effect of analgesic, whether this particular painkiller has given any relief or not. So one very commonly used and a very popular one is the rheumatic or the numeric rating scale or the visual analog scale. But this is a unidimensional scale in which the patient rates his pain from 0, no pain, to 10 is the worst possible pain. But then this is like sometimes if the patient is having total pain, pain of cancer or pain of some other disease, there are psychological issues also, then patient might over-report or under-report. So this is not a very reliable tool, but definitely it's a very simple way of validating. Then there are other multi-dimensions tools like McGrill pain score and brief pain inventory. But all these have certain limitations, like if the patient is old, if the patient is having deafness, or there are cognitive decline, or the patient is suffering, there is Alzheimer's, then it is very difficult for the patient to keep on writing these brief pain inventory, because this is a big scale. It has some 9 components. You have to write all those. So patient doesn't have that kind of a patience, or maybe patient is unable. So then the palliative care person, like the healthcare professional, has to be very compassionate and has to see and observe how and what kind of pain the patient is having. And then accordingly, the treatment has to be given. In addition to that, you have to see what is the, currently, what is the patient doing for his pain? What kind of treatment the patient is taking, whether the patient is doing some non-pharmacological treatment like ice, heat, some physiotherapy, some occupational therapy, or is he taking some over-the-counter medications or some herbal medicine for pain, or actually has he been prescribed some painkillers? And if yes, what was the medicine he's taking? What was the starting dose? Whether this dose was effective or not? Whether and what kind of schedule? Because in India we have a very bad habit of taking painkillers when we have pain. Half the time the patient comes to the pain clinic, if you ask the patient that you were prescribed pain, some medicine for your pain to be taken twice a day or thrice a day, the patient would say, "No, doctor, I took it for just once a day, or maybe when I had pain." So these kind of problems are there. So you have to evaluate the effectiveness of the current pain regime, what the patient is taking, if the patient is having side effects or anything. Now, in the year 1986, the World Health Organization came out with the ladder of pain. This is a very popular ladder, and this is a very easy way of prescribing drugs. In this ladder has 3 steps. Initially it used to have 3 steps. Now the 4th one has been added. The first 3 steps would be: step 1, mild pain; step 2, moderate pain; step 3, severe pain. So when the patient has, it depends on the patient. So if the patient says he has mild pain, then the doctor advises the drugs. So those are non-opioids in the form of paracetamol or non-steroidal anti-inflammatory drugs, or the adjuvants. Or it could be, if the patient says he has moderate pain, then there could be, the patient would be prescribed weak opioids like tramadol, codeine, and dihydrocodeine, along with adjuvants. And if the patient had severe pain, then strong opioids were advocated in the form of morphine, which is the most commonly one used, and the others are buprenorphine patch or a fentanyl patch, and even methadone, oxydone. Methadone is now available in India, so that is being used. And then when you say adjuvants, they include the antiemetics, the antidepressants, the anticonvulsants like the ones which were discussed in the previous two speakers, the muscle relaxants, and even steroids and bisphosphonates. So, but the problem with this WHO ladder is it's a unidirectional ladder. So if the patient says he has mild pain, you start with step 1, and then you move on to the step 2 and then step 3. But the problem is, if the patient has severe pain, then you have to actually go in the other direction. So you should be using this ladder in a bi-directional manner. So you can start with the step 4, which has recently been introduced, the invasive interventions like the MIPSI we were talking about. Those can be done even with step 1, like with non-opioids and adjuvants. You can still do the invasive intervention. So it's a bi-directional ladder, it is to be used. And second limitation of this ladder is that sometimes it happens because the patient has mild pain, you advise non-opioids. Patient thinks that these are not, when you say non-opioids, these are the non-steroidal anti-inflammatory drugs. Patient keeps on taking those for a long time, and those will cause many side effects. They'll affect the kidney, the GIT, and so many other issues. So it is very important that we have to take non-opioids for a specific period of time and then switch over to the next. And many experts are saying that weak opioids in palliative care has not much role. It is better to give smaller dose of strong opioid. So instead of giving a weak opioid in the form of tramadol, you can switch over to morphine straight away. That is what most of the experts are saying these days. But there are certain myths which involve the use of opioids, especially morphine. Whenever somebody is prescribed morphine, people think that the patient thinks that he's terminally ill and he's going to die. And even the doctor only prescribes morphine when it is end of life, but it is wrong. Actually, morphine can be started very early. It doesn't hasten death. In fact, it improves the survival time. If the pain is relieved and pain is relieved effectively, definitely the survival of such patients will improve. Then there's another myth that injectable morphine works better. No, it is always that you have to start with oral preparation, because there is no point in giving injectable unless the oral morphine is not, you are not able to give the oral morphine. Then again, the same thing, that strong opioid should only be considered once the patient is nearing death. That is wrong. Actually, strong opioids can be considered for moderate pain as well. And whenever there are normal vital signs, there is no pain. This is another myth. Whereas in our Indian population, because they don't complain of pain, they can even go around walking with pain, severe pain with normal vital signs. And again, in COPD patients or heart failure patients, you can't use opioids because that is going to cause respiratory depression. In fact, if you give good pain relief, the patient is not going to wash off carbon dioxide or hyperventilate because of pain. And so the patient is going to be improving. There will be improved oxygenation. And opioid use will lead to addiction. No. Whenever a patient is pain, patient cannot go into addiction by use of opioids. So when we talk of oral morphine, there are a few practical points. I can't go into the details, but small things that it is not reserved for severe pain. You can use it in moderate pain also. And it's not reserved for terminal stage. You can use it in any kind of pain. But opioids do have specific indications. In our country, opioids are not used. I mean, they are easily available. Now the drug authority has actually made opioids available all through the country, and they've made it really easy. They have eased on the NDPS acts and everything, and they have actually trained people how to use opioids. But people are still scared to use opioids. So like I said, the route of choice is oral. Even if the bioavailability of morphine is more with intravenous, but definitely the route of choice is oral. Why? Because if the patient is suffering from some prolonged illness, he's going to require his lines for so many reasons. Why spoil his veins for morphine when he can do with oral tablets? And always start with the lower dose. Our Indian population, like we have already discussed in the previous two sessions, that they don't require very high doses. So start with 5 to 10 milligrams per oral. And for morphine, the half-life is so short, so you have to do a 4-hourly dosing. And don't do it like when required. It is never like that. You have to do it on a 4-hourly basis, and never start with a sustained release. Always start with the immediate release one, and don't use the strong, long-acting contain tablets and all. Start with the shorter acting, and then you stabilize on keep on giving every 4-hourly. Start with a 5 milligram dose. Suppose it works out to be 30 milligram, and the patient has good response with that. Continue on that dose. In case the patient has pain in between, then you can keep on increasing the dose. And what you have to do is give 50% of the dose you have started. Suppose if you're given 10 milligram, give 5 milligram dose for breakthrough pain. And then you can calculate the dose of opioid required and divide it into 2 divided doses. And then you give it as morning, evening. So that will be a sustained release one. But when you're using a sustained release tablet, remember, you have to warn your patient not to chew the tablet. not to break the tablet, because that's a sustained release one. So you cannot use it as, you can't just break it, or it's not a excoriable tablet. And for our populations, and especially for the frail, the elderly, and patients who are having organ dysfunctions, you, you must give a smaller dose. And always prescribe a laxative for constipation, and something for nausea and vomiting. Whenever any prescription of morphine, it is a must to have a prescription of laxative along with, whether it's a stool softener or whether it is a laxative. You have to. Now for neuropathic pain, because all these patients of palliative care, they also do have neuropathic components. So you add adjuvants. So there is a ladder for the neuropathic aspect. So corticosteroids have a good role to play for any nerve compression, any tissue edema. So corticosteroids can be given. Then tricyclic antidepressants, like we've already discussed, or anticonvulsant like pregabalin or carbamazepine we can give. And you have to give in step 2 either tricyclic antidepressant or anticonvulsant. In the step 3, that means if the pain is intolerable or it is severe, then you can add, and there are combinations available like pregabalin with nortriptyline you can give, or you can give gabapentin with nortriptyline or amitriptyline. Then NMDA receptors can be used as painkillers in neuropathic pain. And again, it's a bidirectional one. You can give invasive blocks, or invasive technique can be started in the beginning only, but as and when it is required, the invasive technique has to be done, and that is what we as pain physicians are trained to do. So whenever you are prescribing your whether for neuropathic pain, whether for nociceptive pain, for any kind of pain, we have to try with the oral dosing of drugs whenever possible. Avoid IV, avoid rectal, avoid subcutaneous, because these routes are going to be required later in life. And always give it round the clock. Then on demand administration. Do not give it on demand, because that is like patient will have pain, good pain relief, and then once again patient will have pain. So patient will be in and out of pain again and again. So it is better to give it by the clock, according to the pharmacokinetics of the particular drug you are using. And analgesics must be prescribed according to pain intensity, as by evaluating the pain scores. I mean, you can escalate and also de-escalate. If the patient is improving, for adjuvants, like it will take time for the drugs like for neuropathic pain drugs like tricyclic antidepressants or anticonvulsants, it takes a minimum 2 to 3 weeks for them to act. But then you keep on escalating the drug till the patient either gets good effect or the patient gets side effect. And once the dose is fixed, then you keep on giving that dose for some time till there is good pain relief, and then you start de-escalating also depending on the pain severity score. So the therapy has to be individualized. You cannot fix the dose. That is the problem with pain medicines. The dosology is adapted to the patient, and proper medication adherence has to be done. And you have to tell the family, the healthcare professionals, that any dosing alteration can again lead to pain recurrence, like I told you. So it is very important that we should follow the instructions of the doctor. So when we come to the interventional part of pain management in these palliative care, we have lots and lots of procedures which can be offered to the patient. Like we can offer continuous infusion of opioids. We can offer neuroaxial analgesia, epidural and intrathecal infusions, and even epidural steroids can be given. And sometimes you can keep an implantable pump, and these pumps patients can get opioids, and even baclofen pumps have been given and implanted for pain relief. Then you can give nerve blocks in the form of local anesthetic nerve blocks or neurolytic nerve blocks. Then trigger point injections, like already you can give it and then dry needling has a very important role to play in management of pain. And of course, neuromodulation. But in our country, this works out to be very expensive. But nowadays, it seems that the insurance companies are covering. So spinal cord stimulation and peripheral nerve stimulation does have a role to play in management of pain. Some neurolytic, somatic and sensory nerve blocks can be offered, like for CA maxilla or mandible. You can offer a peripheral nerve block in the form of a maxillary or a mandibular nerve block. Or even you can offer a paravertebral block for CA lung or rib secondaries. You can offer an intercostal nerve block, and even deep and superficial cervical nerve blocks for any malignancy or any condition or painful condition of the neck. So these things can be offered. And then even radiofrequency ablation can be done of all these nerves. Then sympathetic plexus blocks have a good role to play in management of pain, especially cancer pain. So stellate ganglion block can be given for any condition of the upper limb, neck, chest, or and celiac plexus block can be given for CA liver, pancreas, stomach, and lumbar plexus block for pelvic and lower limb pain as carcinoma, and then others like ganglion impaired block for CA rectum or any pelvic malignancy, ganglion impaired block can be given, so on and so forth. In this particular patient shown in the picture, we are giving a celiac plexus block for a CA pancreas patient. So we have a lot of non-pharmacological options, and sometimes a small dose of radiation does help in decreasing the pain. Then certain relaxation therapies and mindfulness, physical therapies, occupational therapies, then TENS has a role to play, acupuncture, massage therapy, ice and heat, compression, and other things. There are certain common pitfalls with the management of pain in palliative care. First of all, is very important is lack of communication. It is very important to communicate properly with the patient and the family to find out the type of pain and what the patient is suffering, how much the patient is suffering. And it is very important never to give false and unrealistic expectations. Like, the patient should not be given to understand that now that you have started with this treatment or painkiller, your pain is going to be 100% fine. It's not like that. Patient has to be given a proper hope like this. Yes, the pain will decrease, it will take time, and definitely you will get some side effects also, and you have to explain about the side effects to the patient so that patient is prepared. Like, or most of the patients will have constipation, nausea, vomiting, itching with opioids, so you have to give a prescription and tell the patient that these are the problems and you are going to face these problems and you have to take these medicines for this. You have to discuss everything with the patient before starting the patient on any medicine, any treatment, or even for any invasive management. Certain opioids like morphine have neurotoxicity also, because it has a very active metabolite, that is 6-glucuronide, and this can cause sedation. So you have to be careful about the neurotoxicity and tell the family members the patient might have seizures or something, then they have to report back. And there's a very common, not a very common condition, but there is one condition, hyperalgesia with use of opioids. And in case that occurs, the exact mechanism is not known, but in case that occurs, you have to decrease the dose or you have to change. Then you have to go in for opioid rotation. I'll not go into the details of opioid rotation. So that's a big topic in its own. So the take-home message is that pain is common in palliative patient. Not all patients are the same or should be treated in the same. You should know your patient's history and the type of pain they are having. And you have to tailor your pain regime to their specific needs. And depending on their body habitus, their physique, the type of disease, and their organ dysfunction, you have to tailor the regime. And there is no one right answer for pain management. You have to try different ways and means, different combinations, different drugs, and different approaches. Keep taking great care of your patients. Thank you. Yeah. So any questions?
Ma'am, I have sent the questions in the chat box.
Just let me see. Just a moment. Just a moment.
Ma'am, oh, there are questions, yes.
Yes.
Should I read, ma'am?
The role of non-steroidal anti-inflammatory drugs adjuvants are to be continued even when escalated to step 2, step 3 along with opioids. If that's a comment, yes, you're right. But actually for palliative patients, for pain management, if you're following the WHO ladder, which is the easy way to do it, then you have to continue with the non-steroidal anti-inflammatory drugs if you feel that it is a nociceptive pain. You can't continue non-steroidal anti-inflammatory drugs for a long time. Adjuvants, yes, you have to continue, because adjuvants could be tricyclic antidepressants, adjuvants could be anticonvulsants, adjuvants could be steroids, but steroids also cannot be continued for a long time. So you have to see the patient and decide whether what can be done for these patients. But definitely, yes, when you're switching to step 3 along with opioids, you have to continue these drugs. The role of non-steroidal adjuvants are to be continued, yes. Excellent discussion, very similar put by Dr. Babita, clarified further by Dr. Nandita. Anything else somebody wants to ask? Any more questions? Or have I missed on something?
No, ma'am, not yet.
Okay. Basically, chronic pain is like difficult condition. It's a very debilitating condition, and it affects millions of people in our country, in fact, worldwide. And it's a difficult, condition to treat, because these patients, it is challenging, because we don't have a lot of pain clinics in the country, and pain perception varies. And it is it is very difficult to find one size to fit all. So you have to weigh your risks and benefits and then decide on pain management, that how we are going to manage pain. So if there are no more questions, can we wind up, Dr. Uma?
Yes, ma'am. I think Rupsa can call in Dr. Shri madam for the vote of thanks.
Ma'am is here. I hope.
It was an excellent webinar presentation on a very difficult to treat condition, chronic pain, with lot of research ongoing and various interventional procedures. Shri madam, if she can come in. Should I call her? I'll just make a call to her.
Ma'am has came.
Uma, I'm here.
Yes, ma'am.
I'm here, very much here.
Good evening, ma'am.
Yes. Thanks, Uma. Thank you so much.
Thank you, ma'am. Thank you for the
So
opportunity.
much, Nandita, Babita, and Vanita. Thank you so much for that extensive coverage on chronic pain. And we finished answering all the questions. No more questions?
Yes, ma'am. No questions. No more questions.
I know, because it's such a complicated thing. Every time you have to really read these things again and again, then you understand. So thanks a lot. And Diwali is nearing, and it was such a busy schedule for everybody. And you all took out time for the students and for the other people, delegates. Thanks a lot, and take care, and wish you all a very happy Diwali.
Thanks.
Thank you, Uma. Thank you, Sanish.
Thank you, ma'am. Happy Diwali. Thank you very much.
Thank you,
Happy
ma'am. It
Diwali
was
to
a
all.
privilege. Thank you, ma'am. It was a privilege. Thank you so much.
Thank you, and we'll see you more often. Thanks, Vanita.
Thank you, ma'am.
Babita.
Thank you so much.
Thank you so much.
Thank you.
Happy
Good night.
Diwali.
Okay, ma'am.
Happy Diwali. And
Happy Diwali
thanks,
to all.
Learnets. Thanks a lot.
Thank you, ma'am.
I remember
Thank you, Rupsa,
Debunina's
and
name.
thank you, Dr. Uma. You actually was there all the time. Thank you so much.
Yes,
Ma'am,
she did a
thank
very
you,
good
and the
show.
pleasure is mine.
Yeah. Okay.
Thank you, ma'am.
Bye.
Bye, ma'am.
Good
Happy
night.
Diwali.
Good
Bye,
night.
ma'am.
Bye.
Good night, ma'am. Bye.
Thank you so much, everyone, for extending
ma'am.
us the opportunity to host the session. So with all your permission, I'm signing off here and looking forward to host you again. Thank you so much.
Thank
Bye,
you.
bye.
Thank you. Thanks a lot.